Hello. On behalf of the SOE, I would like to welcome you to the SOE web air on Retina. I would also like to welcome my friend and colleague, Lubomir Litvinchuk, who will moderate this session with me. Before we begin, I would like to run you through some quick housekeeping items. Audience questions. You can ask questions via the question and answer, and we will be looking at them and trying to answer as many audience questions as possible. However, if you have a particular question after this webinar that was not answered, please email it to soewebinars@soevision.org, and we will try and answer them in a separate document, which we will then access via the SOE website. This webinar is being recorded and will be available later via the SOE website and placed on the SOE YouTube channel. I would also like to talk you through the running order for today. There will be 5 presentations in total, and after each presentation, a short question and answer will take place. So please make sure that you submit your question during the presentation. If you would like to ask a question, simply submit it via the question and answer section on Zoom. As you know, macular holes have a high success rate when the routine surgery with vitrectomy, ILM peeling, and gas is performed. However, there is a group of more difficult cases which do not respond so well to this surgery or might not need surgery. In the symposium, an overview of classifications will be given. New technologies for the management of large, persistent, or myopic macular holes will be shown, as well as the latest results with the transplantation of amniotic membrane for hole closure and visual gain by experts in their fields. I'm really proud to have this renowned expert in vitrectomy together with me in the symposium.
Thank you, Susanna, for this invitation. And we would like to start this symposium. For sure, we will talk about the special group of the patient, and these are not these cases which we call simple macular hole cases, but we will talk about more advanced cases which has a lower rate of success with the conventional surgeries. And I would like to invite Professor Binder to her talk. This is introduction talk about introduction in definition and macular holes. Please, Susanna.
Thank you. As an introduction, I would like to share with you some thoughts about macular holes, definition, pathogenesis, and unusual cases. By definition, a full thickness macular hole is a neurosensory interruption involving all retinal layers in the fovea, leading to central vision reduction. There are 2 diseases which have to be differentiated from a full thickness hole. One is a macular pseudohole, which appears as a reddish round or oval lesion between 200 and 400 microns seen on the slit lamp. It shows no OCT, shows no loss of foveal tissue on the OCT, and there is always a concomitant epiretinal membrane with central opening or thinning. The traction here is mainly centripetal, and there is a steep macular contour to the central fovea with near normal foveal thickness. Surgery is only recommended if the epiretinal membrane causes decline in vision. Then the second disease is a lamellar macular hole, which is defined as incomplete macular hole where the photoreceptor layer is intact and therefore vision only slightly impaired over a long time period. If surgery is performed, ILM peeling is always recommended as an important step in surgical repair. Only the need of an additional gas tamponade might be discussed. Haritoglu and co-workers differentiated between a tractional lamellar and a degenerative lamellar hole. While a tractional lamellar hole shows a clear pre-retinal membrane, as you see here, a degenerative lamellar hole presents with more intraretinal tissue loss and cavitation and an epiretinal proliferative tissue heap instead of a clear membrane. A better surgical outcome for tractional lamellar holes than for degenerative lamellar holes is reported. Now, the pathogenesis of a full-thickness hole is still not fully understood. There is a male-female ratio of 1:3 or 1:4. The mean age is 69 years. Primary full-thickness macular holes are related to vitreous traction, and this can be an anterior-posterior traction, which is based on a firmly attached posterior vitreous cortex, and tangential tractions, which are induced by pre-retinal membrane formation. Secondary full-thickness macular holes are based on other pathologies like trauma, surgery, or uveitis. There's also subclassification of macular holes, and we divide them in small, medium, and large. Larger means more than 400 microns in diameter, and actually 50% of macular holes are large macular holes. Since Gass published his observations about macular hole development in 1991, we still divide this development in 4 stages. Stage 1, an impending macular hole where only a retinal cyst develops related with vitreous traction. Stage 2, complete opening of the cyst roof, which results in a fully detached operculum suspended on the posterior vitreous cortex. Stage 3, now the photoreceptors pull away to form a full-thickness retinal hole. And stage 4, when the edge of the hole becomes more elevated and subretinal fluid is also deposited in the hole edges. The standard treatment for a macular hole is still vitrectomy with the use of dyes, ILM peeling, and gas tamponade. In a meta-analysis, it was shown that ILM peeling for macular hole stage 2, 3, and 4 was highly successful and also cost efficient. How about size and duration of full-thickness macular holes? Several studies showed that ILM peeling, which is a dangerous procedure or a very challenging procedure, might not be necessary in small macular holes and when combined with vitreous traction. However, in eyes with larger holes, ILM peeling does improve closure rate and is recommended. Additional aids for used in surgery like TGF-beta, blood, serum, and silicone oil did not show convincing results. Very recently, a study was published in Ophthalmology where pneumatic vitreolysis with C3F8 gas was used for macular hole closure, and also a third of these cases achieved closure. The study was stopped because severe retinal complications did occur, like retinal holes or retinal detachments. What are the open questions now? Are there other factors like the mechanical factors caused by traction? Are there intercellular processes, hydration or inflammation, which might be treated medically? Or is there a role of neurodegeneration, which we don't think about? Since 2015, Dr. Gentile and also others reported about the closure of macular hole with anti-inflammatory drugs and no surgery. In the following 2 slides, I would like to show you 2 unusual cases which I have treated over the last years. Number one is a 57-year-old male. He was diagnosed with a macular hole on both eyes. And at first visit, he had a stage 4 macular hole on the right eye and a stage 2 hole on the left eye. I performed surgery within 1 week, combined with cataract surgery. And on the right eye, I did ILM peeling, and on the left eye, I did foveal sparing vitrectomy. Also, both eyes showed closed holes 2 weeks after surgery. 5 weeks later, the right eye showed a reopening of the macular hole. I injected gas again. I did a free flap surgery, which was not successful. So in this stage, I thought about the publications of Dr. Gentile and Skonder, and I injected parabulbary 20 milligram Volon in the right eye of the patient. Left eye was still normal. Now, 4 months later, this macular hole decreased in size, but the left eye showed a reopening. So I injected the cortisone on both eyes. Now, further observation showed a closure of the right hole, but the left hole reopened. And actually, it developed to a very cystic hole. Now, again, cortisone was applied on the left eye. The vision, fortunately, on the right eye did improve and reached full vision several months later. The left eye, here the macular hole became smaller, but not completely closed. I could not see the patient because of corona. I talked to him on the phone. He said he doesn't see the dark spot anymore, but I think I will see how he's doing within the next weeks. Case 2 was a 60-year-old colleague. He is a radiologist, and he had surgery for macular hole and with simultaneous cataract surgery in 2017 in his right eye. He is slightly myopic. The surgery somewhere else was primarily successful with good vision, but then a macular edema developed, and this was treated with anti-VEGF injections and Diamox for a while. I did see this patient first in 2018. He was rather disappointed because they wanted to continue anti-VEGF treatment, and he felt that this treatment is not going anywhere. At first visit, I did see a chronic urban gas macular edema on the right eye. The left eye was normal. So Volon cortisone was injected parabulbary, and over the time, he received multiple injections every 3 to 4 months on his right eye. The edema went away completely, and slowly also the vision improved on this eye. Unfortunately, now the left eye developed a small macular hole, so we received the same treatment on the left eye. The left eye responded well to the cortisone treatment. The right eye was stable. Now, unfortunately, the vision dropped in this patient because he developed a cataract, and he was horrified to have cataract surgery where he feared he might have Irvine gas syndrome and also vitrectomy. So I combined cataract surgery with a cortisone injection, and so far he's doing very well. His vision is improved now to 0.8 and Jaeger 1 and 2. So I believe that the role of inflammation in macular hole development is unclear and might be underestimated. There's also a neurodegeneration where we do not know which cases are prone to it. Also, the primary pathogenesis of full thickness macular holes might be mainly tractive. There are many other factors involved. While small and medium holes respond well to standard surgery or even medical treatment in selected cases, large chronic holes do not. And here you see that stage 4 holes have only a healing rate of 56%. So a little bit more than half of these holes will be treated successfully with standard treatment. Clearly, new approaches are needed for macular hole management, as well as a better differentiation of cases. The management of the most difficult macular holes will be presented in the following talks. Thank you very much.
Thank you, Susanna. It was a nice overview of the macular hole problematic, and as you told, the inflammation for sure take place, and unfortunately there is no possibility to maybe to investigate this rate of inflammation and the severity of inflammation live, and we do not have any not many information about postmortem, and as we know, any failure in anatomical failure undergoes with the inflammation. And usually this chronic inflammation causes difficult types of adhesions and fibrotic tissue proliferation and so on. So probably this might play a role in this more difficult cases, which have a rate of 50%, a little bit more than 50% with the conventional surgery. And we would like to go further on and to invite to this talk, do any of the panelists, do they have any questions to Professor Binder?
Can I answer? Yeah, I think, I'm a surgeon from my deepest heart. And I do not believe that, cortisone is the cure now and we should all switch. But I think there are some factors we overlook. And there might be a group of cases where we can try medical treatment, especially in reoperations or incipient very small holes. That's all I'm saying. And now I would like to announce our second speaker. Thank you, Lubomir. If we don't have further questions, we can continue. And I would ask Professor Sophia Anna Nawrocka, who will discuss the inverted flap technique in atypical full thickness macular holes.
Ladies and gentlemen, I am happy to be here with you. First of all, I would like to thank Professor Binder, Professor Finchung, for inviting me to be here with you. My standard technique in all cases of macular holes, and I will focus in this presentation on atypical ones, is always the temporal inverted ILM flap technique. It's a modification of the original one. After staining with membrane blue, as you can see, I peel the ILM only from the temporal side of the fovea and then cover gently the full thickness macular hole. We already published in a prospective comparative randomized study that the temporal inverted ILM flap technique is non-inferior in regard to visual acuities and the closure rate when compared to the original inverted ILM flap technique, published by our group in 2010. A big advantage of the temporal inverted ILM flap technique is saving the retinal nerve fiber layers at the nasal side of the fovea. But additionally, we published recently that it saves some vessels in the deep fovea vessel layer. You can see that there are some disturbances of those vessels in Swabster's OCT angiography in the peeled area, not visible in the area when the ILM was left intact. Now coming to the atypical cases of full thickness macular holes, starting with the myopic full thickness macular holes, it was the first indication besides large long-standing macular holes to use the inverted ILM flap technique. Kuriyama, our group, and others confirmed it is successful, and we can give our patient an improvement of the visual acuity with this method. We must understand that macular holes in high myopia have slightly different etiopathogenesis from idiopathic cases. Besides traction, elongation of the eye and chorioretinal atrophy play a role in the development of full-thickness macular holes in high myopia. A recent meta-analysis compared papers presenting the technique originally described by our group, namely the inverted island flap technique, the cover technique, with the insertion of the flap inside the macular hole. And it occurred that in macular holes without retinal detachment, both the closure rate and the improvement of visual acuities were higher in the cover technique. So we should not put the ILM inside the hole in those cases. The more demanding cases of macular holes coexisting with retinal detachment give us the same results, and it's especially important in regard to visual acuity. As you can see that it is the visual acuity is significantly better in the group where the ILM was only gently positioned on the top of the fovea. Another rare indication for the inverted ILM flap technique is the Coats disease. In the literature, I found only several papers for the last 60 years on this rare complication of the Coats disease. And 2 of them reported that the closure process might take even up more than 6 years in order to close the macular hole. Those patients are usually much younger than that we meet during idiopathic macular hole surgery. And as it is obvious in younger patients, the removal of the posterior hyaloid might be much more demanding. The structure of the ILM in Coats disease is also slightly different from idiopathic cases. Because of that, you can see that I peel the ILM not only temporal, but from the superior side of the fovea in order to cover the macular hole. The closure process takes also much longer. You can see that the fovea is slowly closed during more than 1 year after surgery, achieving final anatomical and functional success. Another rare indication are macular hole coexisting with age-related macular degeneration. There are only several studies. Most of them report that visual acuities and the closure rate is lower than in idiopathic cases. Because of that, we started to use the temporal inverted ILM flap technique in full-thickness macular holes, which coexisted with dry age-related macular degeneration. In this movie, you can see an eye with many soft drusen, in which we performed the temporal inverted ILM flap technique. And of course, the cover technique in this situation. This report is already published, and we noted that the anatomical success is almost 90%. It's with this first surgery, and it's slightly less than in idiopathic cases. The final visual acuity in this group was 0.5. But what is important, there is no significant correlation between the macular hole diameter and final visual acuity, and that it is different than in idiopathic cases. Probably because the underlying disease, age-related macular degeneration, influences also the final visual acuity. But there is a strong correlation between visual acuity before surgery and the final visual acuity. Interestingly, we observed new drusen in 7 eyes in our study group, and they decreased in size in 4 patients. Such a disappearance of drusen after vitrectomy was already described by Holtz, Lee, and others, and it was attributed to the phagocytosis of drusenoid material after the removal of the posterior hyaloid. In one case, we observed that geographic atrophy developed 12 years after successful macular hole closure. And in also one case in our study, we observed that there was a choroidal neovascularization years after closure of the full-thickness macular hole. It's a very rare complication described in one in more than 200 cases in the macular hole study group. And those cases can be normally treated with anti-VEGF. Another rare situation are macular holes coexisting with age-related choroidal atrophy. Age-related choroidal atrophy was first described by Spady and might be differentiated from geographic atrophy in autofluorescence, where it shows no changes. Those patients have preserved the distance visual acuity with decreased near visual acuity. What about these patients? He encountered spontaneous closure of the macular hole without any surgery, but almost 1 year later developed choroidal neovascularization in the eye after spontaneous closure of the full thickness macular hole. Here you can see Swepser's OCT angiography of this case of age-related choroidal atrophy with later development of CNV. Another rare situation is the development of full thickness macular hole during the treatment of active choroidal neovascularization. The question we might ask ourselves is whether we should perform surgery, as obviously it might have some influence on the washout time of the anti-VEGF, and this patient was continuously treated for 10 months for choroidal neovascularization. Because of these questions, we waited for 3 months until we decided to make vitrectomy. During the meantime, we thought about the washout time of anti-VEGF, and based on our studies in endophthalmitis and on the DRCR network, that described there is no problem with further anti-VEGF treatment after vitrectomy, we decided to treat this patient. And here you can see a video. This is a patient treated for 10 months with aflibercept, with choroidal neovascularization, some underlying drusen. And here also we performed the temporal inverted ILM flap technique, taking the smallest amount of vitreous out of the eye, performing only core vitrectomy, and making a small peeling on the temporal side. 1 month later, we observed that the macular hole is closed, and until now, the patient is treated every 1 or 2 months with aflibercept, and the final visual acuity is quite satisfying. Another rare indication and rare coexistence of full thickness macular holes is diabetic retinopathy. What is interesting and a little different from idiopathic cases, that even in non-proliferative diabetic retinopathy, in most cases, the results are worse than in idiopathic eyes, and that we observe some small persisting photoreceptor defects many months after surgery. We also observed in about 30% of eyes some hyperreflective remnants of the ILM on the top, on the surface of the closed macular hole. Of course, we were a little worried about the possible proliferation in those cases, but we performed another study on idiopathic eyes and published it in Retina with longer observation time, and none of those cases with this hyperreflective remnant presented to you by the arrow, none of them developed to any proliferation afterwards. So such an appearance might be observed also in diabetic retinopathy. Proliferative diabetic retinopathy coexisting with full thickness macular holes shows us an appearance maybe slightly similar to that occurring in high myopia. That means that the minimum to maximum diameter ratio, which is in idiopathic cases 1 to 2 usually, that is in myopia, and in proliferative diabetic retinopathy, rather 1 to 10. So we encounter detachment of the retina and a very big maximum diameter. Here you can see surgery performed in those cases. In some of them, silicone oil must be used. In this case, we peel the ILM from the further periphery, as this is an eye which developed a full thickness macular holes with fovea detachment after earlier vitrectomy. So you can see we had no ILM in the fovea. We had to perform a pedicle flap. It is some modification of the autologous island flap transplantation. You can see it can fly over. You have to position it. We usually use viscoelastic material to do that. And as you can see in this slide, the closure process in proliferative diabetic retinopathy is prolonged. It might last several months. You can observe during that time some subretinal fluid that resolves spontaneously from itself, but it takes a longer time than in idiopathic cases. And the maybe most interesting and most rare indication for the inverted island flap technique does not concern the macular holes, but the optic disc pit. And in order to treat maculopathy in the optic disc pit, we should push the ILM inside the optic nerve. As a conclusion, I would like to state that the temporal inverted island flap technique is non-inferior to the original inverted island flap. It should be always gently laid over the surface of the full thickness macular holes. Pushing inside is only possible in optic disc pits. And we can close with this technique full thickness macular holes coexisting with AMD, high myopia, non-proliferative or proliferative diabetic retinopathy, or Coats disease. Thank you for your attention and hope to meet you live in the next meeting.
Thank you very much, Sophia. We now have the time to discuss your presentation. I really enjoyed your difficult cases. We have already 2 questions, which I would like to read to you. Number 1 is, have you noticed any correlation in the rate of macular hole closure and type of surgery, combined phaco pars-plana vitrectomy, or phaco with subsequent pars-plana vitrectomy 1 month?
First of all, thank you very much once again for the invitation. It's very nice to be with all of you here. And coming to the question, I do not use combined phaco-vitrectomy in all cases. It's not my routine. I do it only if the patient has significant cataract. And I did not observe any correlation. I don't think that the additional cataract surgery has a negative or positive influence on the final outcome of the macular hole surgery. In fact, we usually observe cataract formation in the first year after surgery. So it might be reasonable in some cases surgeries to make it combined.
Okay, thank you. We have another question.
Yes, and should I come to the next question?
Yes, please. Question number.
Yes, I can.
Can you hear me?
Yes, now I hear you good. Now it's okay.
So do you no longer place the inverted flap into the hole? I think you have already answered this during your talk, but perhaps you can repeat this again.
Yes, thank you. That's an excellent question. We never did place the inverted flap inside. It was somehow probably misunderstood, but the original idea of the inverted island flap technique from the first study was just to cover it gently, to peel the ILM and to put it over the macular hole. We never did pushing inside, but some surgeons did. And because of that, there are several studies comparing the pushing technique and the covering technique. The covering is our original one. And indeed, it is associated with better visual acuities. I presented that from a comparative study in myopic macular holes, but it was also confirmed in idiopathic cases. So it is better to leave it on the top of the fovea than to push it inside.
Thank you. I have a last question. Are there still cases, Sophia, do you hear me?
Yes.
Are there still cases where you do routine vitrectomy, ILM peeling and gas and nothing else?
Sometimes in young patients with very small macular holes, I do just ILM peeling, but in general, in 99% of my surgeries, I use the temporal inverted ILM flap technique.
I have also one question to Zofia. Thank you very much for your presentation. It's very nice to see you and during this webinar. Certainly temporal flap technique has more advantages. Most of all, these are the anatomical sparing of the nasal part of the paranasal, nasal to macular hole. But I had one case which I would like to share with you. I used this was idiopathic macular hole. I used a temporal flap, and the hole was closed, but within 1 month, it reopened. And on OCT, I could see that the temporal flap went away, and the temporal edges of the macula were attached, but the additional, I explained this, so additional gliosis of the ILM on the nasally to the macular hole created the elevation of the nasal rim of the macular hole. Only nasal was elevated. So I did the second surgery, and I did nasal flap because I lost already temporal flap. I did nasal flap, and I was successful with this kind of surgery. Have you seen such a cases that the ELM changes of the remains of the ELM induced the new hole after the closure?
That's a very interesting issue. In fact, I think that all failures of the inverted ILM flap technique are associated with the coming back of the ILM, with repositioning of it. They are extremely rare, but they might be observed, and we also observed such cases in the past. I usually do as you did. So I take the ILM from another part of the fovea and close the hole in the second surgery with a very similar attempt.
Thank you very much. Thank you very much. And we are moving on, and it is our pleasure to invite to the next talk Professor Kastenmeier, Switzerland, from Davos. And Professor Kastenmeier will talk about his brilliant technique, to which he dedicated a lot of time and collected a lot of cases. Thank you, Professor Kastenmeier, for joining us, and please take a word.
I'd like to thank the organizers for the kind invitation, and I have no financial interest to disclose. We all know from Jerry Seebeck that the vitreous plays a critical role during the evolution and the formation of vitreoskisis, epiretinal membrane, and macular holes. We also know from Don Guess about the evolution of macular holes in different stages. And Godric showed us very nicely with the in vivo examination of OCT how macular holes develop. Vitreous plays a critical role, and Robert Macular showed us that with the release of epiretinal traction and removal of the vitreous, we can close macular holes. After my fellowship, I worked also vividly on vital dyes, so that helped us to release all epiretinal membranes and achieve a nice closure of the macular holes. But wait a minute, did we miss something? If you really release everything from the epiretinal surface, all macular holes should close. But there's a little proportion of macular holes that are not closing. I'm not changing the pathology of macular holes. And we know that epiretinal traction is the main cause of macular holes. And therefore, its release by vitrectomy, chromovitrectomy, will close nowadays more than 90% of macular holes. However, persisting macular holes, we still treat from the epiretinal side, namely by silicone application, thrombocyte concentrates, or ILM patch. We hypothesize that fermentations of the retina and the RPE prevent the closure. Thus, subretinal fluid application will release these traction, stretch the retina, and close macular holes. This idea is not new. And during my first Cornell meeting 20 years ago, Gonves, Bove, and Thomas Wolfensberger described this technique in a small case series. It took another 9 years when a group from Poland published their first case report, and another 7 years when Mandelkorn described his technique and named it macular hole hydrodissection. Another group from Canada also described their technique and published a case series where they achieved a nice closure of 16 persisting macular holes, whereas only 2 macular holes remained open. But these were just single-centered studies, and the idea was, how can we achieve more knowledge about it? At the same time, I did my first case with this technique. This was an 83-year-old gentleman who had vitrectomy, repeated vitrectomy with silicone oil removal. And now he was sitting in front of me with a persisting giant macular hole, more than 1400 microns, no ILM pad left for a patch, and a really reduced visual acuity. This hole reminded me of my fellowship at Duke when we did macular translocation. So we applied subretinal fluid to release the retina and drag it downwards. And I measured a shift of up to 1600 microns at that time. I'm going to show you here my video of one of my first cases. It's a pretty forward surgery because the eye is already vitrectomized. You can see here the large macular hole, and it's easier early on when you apply a little PFC bleb on top of the macula, macular hole, because it's easier to detach the retina, because you want to have a nice detachment and you want to prevent that early on the fluid goes through from the subretinal space through the macular hole, and then you cannot expand it anymore. I was amazed when I observed this old gentleman a week after, or 5 days after surgery, with the closure of the macular hole, and he noticed visual improvement later on of 2200. Was this just a lucky case? And I asked myself, well, is this repeatable, feasible, and what is the risk profile? I presented this at the last Vail meeting and discussed this intensively with numerous colleagues, including Susanne.
A novel approach using subretinal fluid may be more effective. It works by injecting fluid under the retina to release the subretinal adhesions between the photoreceptors and the adjacent RPE. First, a small decaline bleb is applied to cover the edges of the hole. Then, 3 small subretinal blebs of fluid are applied around the hole and the arcades in the macular area. The decaline bleb is now removed by shifting it over the optic disc and aspirating. More fluid is injected into the subretinal blebs, so they become confluent and finally connect with the macular hole. The retracted retina around the macular hole is now detached from the RPE. The elastic retina is now mobile and can shift and cover the anatomical area of the fovea again.
After this presentation, numerous colleagues from Germany, Austria, and Switzerland contacted me, and we started a first multi-center trial evaluating the technique. You can see here that of the 12 surgeons, most apply 3 subretinal blebs with BSS. They confirmed that it's crucial that really the edges of the macular hole are detached, and these macular holes behave like normal macular holes, so we have a closure within 5 to 7 days. Of these 41 cases, we didn't experience any serious adverse events, only small subretinal bleedings close to the retinotomy. As tamponade, most use gas, while a limited proportion used silicone oil in their first cases. So what are the results? You can see here 17 months was the average duration of the macular holes, with more than 1200 microns aperture. We achieved a closure rate of 85% with this technique after 6 weeks. So our first conclusion was it's feasible, it's easy to perform, it's a small learning curve, we are used to apply fluid in the subretinal space, and there's no serious complications. After we have proposed our technique, described it, and evaluated the technique in the Apostle study, numerous other colleagues contacted me over the last year. And you also see, if you're experienced enough, like Makoto, you can also apply subretinal fluid with also Dicoline, but you see, once you have a connection to the edge of the macular hole, it's going to stop, and then you have to go to another location. So if you're experienced enough, you can also do without it. As I mentioned, we have now 44 surgeons, 150 cases. The diameter is basically the same, 1100 microns. The majority used gas, only a minority silicone oil. However, we now see that not only conventional idiopathic, but also secondary macular holes are used in this technique. What is the preoperative measures? Again, close to 17 months with a logMAR of 1.16, 6 weeks post-operatively, like in the Apostle study, more than 80% of the macular holes closed. And we measured a gain of 3.99 lines. Now, with this load of patients, we can start a sub-analysis. Here you see the results of all macular holes, and divided into idiopathic and secondary macular holes, you see a difference. Idiopathic macular holes are going to close in up to close to 90% with this technique. In secondary macular holes, it's lower, but you have to keep in mind, in the idiopathic macular holes, we had 7 eyes with a duration of more than 20 months. So probably the retina was already too stiff to close the macular hole with this technique, and 10 eyes had a diameter of more than 1400 microns. And we have really to discuss up to which diameter this technique is feasible. In secondary macular holes, we had 12 eyes with pathologic myopia, 6 after repeated retinal detachments, 2 after trauma, idiopathics, iatrogenic, diabetic macular edema, RVO, AMD, and McTell. So I was still amazed that the surgeons reported a closure rate of 60% with these included eyes. So what can we conclude? We always had a closure rate above 80% in this trial. So 4 out of 5 eyes gonna close with this technique. In the late visual acuity, we determined that we will have a gain of 4.9 lines for all eyes, whereas, as expected, it's much lower for secondary macular holes. What can we conclude? Vitreous traction, macular holes developed by vitreous traction and epiretinal membrane formation. A complete removal of the epiretinal traction will close more than 90% of macular holes. First step. Persisting macular holes are probably also related to firm adhesions of the RPE and photoreceptors in the subretinal space, and therefore subretinal hydrodissection will release these firm adhesions, stretch the elastic retina, and close persisting macular holes. There are other ideas on the horizon that you can combine these techniques. So why can't we, after the Apostle study, apply subretinal fluid in conjunction with ILM flap formation? And you will hear about this in the next talk. Thank you very much.
Thank you very much, Professor Kastenmeier. It was a very nice talk. Susanna, do you have a question?
I wanted actually to ask about the myopic cases, because there, Carsten, do you plan now, is this your first approach in a myopic macular hole?
As you know, most of these cases, we have much less myopic patients in Central Europe, in Germany and Switzerland, so they were predominantly from Japan. But I think that I was amazed that this technique is also feasible to be applied in myopic cases, where, you know, sometimes it's quite limiting, as I showed in my first case, when the ILM is gone. So what kind of membrane are you put on top of the retina? I know that you can use amnion membranes on top of it, but for me, it's very difficult to harvest them in a private practice. And the subretinal fluid application we are very common. We used to use it in macular hole surgery, in translocation surgery, in subretinal hemorrhages. So we have the equipment, everything we have in the OR. So this is a quick maneuver, and it's without any serious complications.
I would like to, first of all, to thank you, Professor Kastenmeier, that he, with his initiative, that he collected so many cases worldwide, because this is quite a rare technique, which is not used oftenly, and only this huge amount of cases can allow to analyze this technique and to discover the pros and cons, and to maybe to think about the improvements of these still remaining 15 or Professor Kastenmeier.
Thank you. Thank you. Well, you know, I have to thank you, because you sent me also your cases and from numerous colleagues. So this study, also this knowledge wouldn't be available if you wouldn't support me with all your cases. Thank you.
Thank you.
Thank you very much. I don't think we have another question. No.
So, but let me ask, let me ask you one question, Suzanne, because there's always a discussion, can we do harm by applying subretinal fluid? And I know that you did suspension of RPE cells in the subretinal space. And currently I'm working on improvements to detach the retina. I know in the early days when I did it with Cindy Toast, we used the BSS and the BSS Plus without it. So do you think, so what is your recommendation as a senior surgeon to detach the retina?
Well, when I detached the retina, I used calcium magnesium free solution.
Yes.
This was what we had learned, that then we would be less traumatic for an artificial detachment. And I think it worked well. But if you overuse it, I have also seen, I don't know who reported that, corneal problems. So I think for a small amount, you will be fine. Yeah,
okay.
I also think it's adhesion related, like in a dry AMD, to separate the retina will be very traumatic compared to an exudative case.
Thank you.
Thank you very much. We will now move to our next combined speaker. Dr. Lubomir Litvinchuk will present the combination of subretinal administration of fluid and inverted ILM flap technique as an alternative approach. Please.
Good afternoon, dear colleagues. I would like to thank you for this kind invitation to participate in this SOE webinar. Thank you, Professor Binder. My name is Dr. Litvinchuk, and I'm talking from Germany, from Gießen. And I would like to focus my talk on the application of an alternative technique, surgical technique to treat the most difficult cases of macular hole. These are chronic, persistent, and large. The intraoperative OCT data showed that during the conventional ELM flap peeling to treat macular holes, we create a strong traction on the retina, and this strong traction is shown over here, and this strong traction can even increase the base size of the retinal macular hole during the surgery. In contrast to conventional technique, inverted lamp technique is meant to peel the ELM in centripetal manner, and together with a retinal massage, macular massage, we can even decrease the macular hole base size at the end of the surgery. And this technique was first proposed by Michalewska and Nawrocki in 2010. And this brilliant technique opened a new horizon to treat difficult cases with macular hole, difficult, challenging cases. The second technique I would like to talk about is a subretinal application of fluid. I was introduced to this technique a few years ago by my friend, colleague from Kiev, Dr. Ruban, and he applied this technique by patients with a post-traumatic macular holes with a subretinal scarring. And the closure rate with this technique in these difficult cases was, we reported was 85.7%. And in cases where we couldn't reach the complete closure of the macular hole, we could reach the decrease of the macular hole size. And there were almost all holes were closed. Professor Kastenmeier, on the larger series of cases, demonstrated also the efficacy of this technique, and the closure rate was similar, 85.3%. And since then, this technique was first described by Oliver and Wojciech in 2011. Since then, there are many there are many variants of this technique and many publications of this technique. And finally, we came up with an idea to combine these two novel techniques to treat most difficult cases with a persistent chronic or large macular holes. In this case, you see there's a schematic view of the temporal inverted ELM flap in order to spare the nasal ELM, and in order to be able to inject without stress, we remove the small areas of the ELM nasally to the macular hole, and we create 4 bubbles. And in this case, this is a schematic view of combination of 2 techniques: subretinal fluid administration and inverted ELM flap. In our case series, we used either inverted ELM flap technique, temporal flap, or free ELM flap technique. Intraoperative OCT can be helpful to control the position of ELM flap at the end of the surgery. But you see, this is a case of chronic macular hole at 14 months, female 54-year-old. We created as well the temporal flap, and we removed the small, tiny areas of ELM nasally to the macular hole in order to inject BSS without the stress to the RPE. We injected the BSS underneath the retina, and sometimes we can see the leakage of the BSS through the macular hole. It means that the rims, the edges of the macular hole have been elevated. So, and this surgery ends up with a fluid-air exchange, and usually with a gas endotamponade and a face-down position of the patient through one night to the next day after the surgery. The closure rate was also very high in our case series, almost 100%. I will talk about this a little bit later. In this case, the macular hole was closed primarily due to reapproximation of the macular hole edges, and additionally, the ELM flap covered the macular hole. In these 3 cases from our case series, you can see a different mechanism of the closure of the macular hole. Here, the primarily closure due to reapproximation. In this case, due to the ELM flap, it was not possible to reapproximate the macular hole rims with a subretinal injection. And in this case, also with the primarily the rims were reapproximated and the macular ELM flap supported the closure of the macular hole. We can follow even the reorganization of the normal retinal structures or retinal layers in the fovea within 6 months. This is case of chronic macular hole, and you see at the beginning postoperatively a tiny reapproximation of the edges with the ELM flap bridge, and then in 3 months we see how in 6 months we see how the inner and outer first of all outer layers of the retina, they reorganize itself, and the close fills the macular hole fills up with the tissue, and the subretinal fluid appeared to cause hyporeflective areas in an autofluorescence, but you can see that these areas, these appearances, they disappear within 6 months. These are the results of our case series, and the best corrected visual acuity increased. All holes, the final macular hole closure rate was 100%, except one case where the second surgery due to the rheumatogenic retinal detachment was necessary. And as a discussion, I would like to present this case from Dr. Ruban. He treated a post-traumatic macular hole, quite large, almost 2,000 micrometers, young male person, and the surgeon injected subretinally the BSS, and then he performed a slight massaging of the retina. The ELM was stained, and the inverted ELM flap was created in order to cover already smaller in size macular hole after the subretinal injection and massaging of the macula. At the end of the surgery, the macular hole was closed with inverted ELM flap, as you can see here, but unfortunately the patient presented in 1 week after the surgery with a rheumatogenic retinal detachment caused by the peripheral hole. But OCT showed us that ELM flap was still adherent to the macular hole partially. And the second surgery was necessary, and here you see the small peripheral macular hole was already with PVR formation. And in that case, the surgeon ought to use a free flap technique to remove the ELM from the sides and under the peripheral decaline to place the ELM, remnants of the ELM onto the macular hole to reassure the closure of macular hole. And this surgery was ended with a silicone oil endotamponade. So as you see, even this case proves the stability of ELM flap. After inverted ELM flap technique, the ELM flap sticks to the macular hole edges and remains adherent even if the retinal detaches. Another thing is the retinal displacement. The subretinal injection of BSS allows us to displace centripetally the retina toward the center of the macular hole. And through this mobility of the retina, we can support the closure of the difficult enlarged macular holes. There are some difficulties in this technique. Sure, our aim is to detach the macular hole and the retinal in the area of macular hole, but it is not always possible and not in every place. And we noticed, as well as Professor Meyer described, the strong adhesions between the RPE and macular hole edges, which we also presented as a short abstract on ARVO 2020. To conclude, I would like to say that surgical treatment of chronic persistent enlarged macular holes remains still very difficult, and the surgical techniques and indications are not very clear, and that's why we came up with an idea to combine one of the very efficient techniques, novel techniques, inverted ELM flap technique. Either this is inverted ELM flap or temporal flap or free flap with subretinal fluid application. And in our case series, the final closure rate was 100%. This is small series of cases. The study should be done on a larger series of cases, but we believe that the synergy of two anatomical impacts of these two techniques namely the centripetal mobilization of the retina toward the center of the macular hole and proliferation of the glial cells underneath the ELM flap, can cover the failure rates of each of these two techniques and bring the closure rate to almost nearly to 100%. We need probably also a more clear definition of the macular hole, or as a classification, as we talk about this segment of the macular hole, which are very difficult to close with the conventional techniques. Thank you for your attention, and I would like to acknowledge my co-authors. This is Dr. Ruban, Professor Meyer, Professor Stiege, Professor Grzybowski, and Professor Richard. Thank you very much. Have a nice day.
Thank you very much, Lubomir, for this very interesting presentation.
I have 2 questions to my presentations.
Can you read them, or shall I read them?
No. I have another 2 questions. The one question is, sure, I learned something from Professor Meyer that Oliver and Wojciech were not the first who described this technique. It was interesting to hear this. And the second technique, and the second comment that I would like to say that this was the question to Professor Nawrocka, that this covering and stuffing this of the macular hole, these are 2 different things, and we already discussed this today and earlier due to our publication and letter to the editor. And for sure, it shouldn't be applied probably, but I think there are some cases, rare cases, difficult cases, when we, at the end of the surgery, cannot control the covering of the macular hole due to different causes, due to different problems, bad visualization, I don't know, displacement of the air fluid exchange or another. So, and in this case, probably this is the best case scenario from worst case scenario. So when the flap is inside, it is better than the flap is out of the macular hole. And there are 2 questions from the audience to us. And would you please ask these questions, Susanna?
Okay. There is a question from Dr. Singh. In what situations do you use a free flap? And how do you get the free flap to stay over the hole and not move around during the gas exchange?
Okay. This quite difficult step. In cases where the ELM is already removed and you don't have any ELM around the macular hole, you have to stain the ELM outside the macular area. And if you are lucky, the surgeon previously did remove a small amount of ELM, and if you are not, the surgeon on the first surgery has removed the area, big area, and this is my impression. But the further we go from the macula, from the fovea, the more difficult is to remove the ELM. The ELM is more thinner, and the removal of the ELM is not so easy. But still, you can find some ELM near the optic disc. You can go even on the 12 o'clock or 6, or even nasally from the optic disc or temporally. But you have to color it, to dye it with the membrane blue, find it, and under the, usually I do this under the PFCL. And during the air gas exchange, this is also quite a difficult, but you leave the PFCL inside the eye and you remove only the fluid first, and then you have only air and PFCL in the eye, and then the air will press the ELM free flap to the retina and gently remove the PFCL at the end.
Thank you. We have a second question, very quick. What kind of instrument do you use for subretinal injection of BSS?
Thank you. These are standard subretinal injections. They are 23 gauge and 25 gauge, but inside these needles, the injection needles, there is a retractable 41 gauge needle, and some companies, they write 38 or 41. Actually, this is the same needle from polyurethane, but this is 38, this is inner diameter, 41 is this outer diameter of the same needle. We also started to use the automated subretinal injection set from Med1 company, so we can connect to the silicone oil injection system, and with with the foot pedal, you can by yourself control the injection of subretinal fluid by yourself. And these systems have been used to inject subretinally the gene vectors and RTPA, and as well subretinal BSS.
Thank you. I think we have to move on. And Lubomir, would you please announce the next speaker?
The next speaker is Professor Stanislao Rizzo from Italy, from Florence, and we would like to give him a stage and to report his technique, because we all know his technique and is also very fascinated. There are some questions that I would like to ask him afterwards, but let's hear first of all this talk. Please, Professor Rizzo.
Good morning, and thank you very much for your kind invitation. The incidence of a macular hole reopening, recurrent or persistent macular hole after the surgery, is around 3.3%. And the main risk factors are, for example, residual epiretinal traction, insufficient gas tamponade, and insufficient face-down positioning by the patient. And we have many techniques, many surgical techniques. For example, we start with some growth factor, for the TGF beta-2 growth factor and the autologous platelet concentrate to pass through the endotamponades, lighter and heavier than water tamponade. And nowadays, the modern approach consists in inserting alien tissues, for example, into the macular hole. But many times with this transplant of tissues, we have some limitations. For example, they often are two-time surgeries. There are complex surgery techniques, and not always we have available tissues. But first of all, we have unsatisfactory visual outcomes by the patients. For these reasons, we proposed some years ago the use for recurrent or persistent macular hole, the use of a human amniotic membrane. The human amniotic membrane is an immunogenic and not immunogenic tissue. It is not with no need for immunosuppressive therapy. Of course, for this reason, a low rate of rejection reaction. And first of all, it's very easily available. The human amniotic membrane is composed by three layers: the epithelium layer full of growth factor stem cells, the stroma layer, and the corneal layer. The corneal layer has some adhesive properties. It remains adherent to the tissue or to your forceps, for example. And before our proposal, there were many papers about the use in vascular research or human amniotic membrane, for example, as support for human retinal pigment epithelium growth, or for its use in retinal pigment epithelium cell differentiation. And this was our first paper, a human amniotic membrane plug to promote retinal breaks repair and recurrent macular hole closure. This was the first impressive case that we operate. A very large macular hole in myopic eye with retinal detachment of the posterior pole, and the result was impressive, not only in terms of anatomical result, but also in terms of functional result. Last year we published this large series about 36 patients affected by recurrent or persistent macular hole 7 of these eyes were myopic with very large basal diameters, at least 1,000 microns, and 23 patients were tamponated with SF6, 13 patients were tamponated with air. And it was the surgery. It was a 25 gauge vitrectomy. We passed through the other cannula in order to allow us to use a very large disc of amniotic membrane. In this case, was a disc, or the diameter of the disc was at least 3 millimeters, and 3 millimeters is difficult to pass through a 25 gauge cannula. And with the bimanual technique, we use this very gentle and, of course, precise technique to insert the amniotic membrane under the edge of the hole in order to use a very short tamponade as air or SF6. And this was the intraoperative to control the perfect position of the amniotic under the edge of the macula, or the macular hole. This was a recurrence of macular after many surgeries, and we tamponade in this case only by air. And this was the results. These were the results of our study. 100% of 36 recurrent or iridium macular hole was found closed at 6 months follow-up. 33 or 36 were closed at 2 weeks. 2 or 36 were closed at 3 months. They were all tamponade only with air, and 1 or 36 need a replacement of amniotic membrane because the amniotic membrane was displaced in IAC myopic eye. There was one of the case pre-surgery. It was a very large macular, extra large macular hole. It was the plug amniotic membrane. At that time, we used many layers of amniotic membrane. We changed a little bit the technique, also, or using nowadays a very thin layer of amniotic membrane. And after 9 months follow-up, we saw that some of the layer of the external layers of the retina were present on the residual of the remnants of the macula of the amniotic membrane. There was another case before pre-surgery. After 2 weeks, there was the plaque of amniotic membrane. After 3 months, there was some tentative of retina to regenerate, and after 12 months, we saw that there were some layers of the external retina. There was another case, large macular with atrophic retinal pigmentalium on the bottom of the macular hole. After 8 months of follow-up, we saw that the external limiting membrane was present over the residual of the amniotic membrane. And in this case, you see, we use a very thin layer of amniotic membrane instead of use a plug of amniotic membrane. This was another case with tissue ingrowth above the amniotic membrane plug, you see, and with formation or layers at the level of the external retina with present of ELM over the plug of amniotic membrane. And also the angio-CT show no difference in the fovea vascular zone and the revascularization of the deep capillary plexus comparing the operated eye with the fellow eye. There was a case of eye with eye myopia. We see a very thin staphyloma on the posterior pole. You see that amniotic membrane after some months the regeneration of the external layers of the retina or above the plug of amniotic membrane. So, what about the results? We have 100% of closure of the hole with surgeries, 97% of closure of the hole with only one surgery. And in eye myopia, we have 100% of closure of macular hole with surgeries and 94% of the closure with only one surgery. Comparing with the other techniques, for example, with with neurosensory retinal free flap, the multicenter study had 89% of closure rate of macular hole. Using the autologous ILM transplant, they had 90% of the closure of macular hole, but the number of the eyes was very low. It was our results best corrected visual acuity. We have the increasing in the best corrected visual acuity, and this result was statistically significant compared with the preoperative best corrected visual acuity in these eyes. In 33 on 36 patients, in about 91%, we have the best corrected visual acuity increased. In 2 or 36, the best corrected visual acuity remains stable, and in 1 or 36, the patient operated with displacement or amniotic membrane, the best corrected visual acuity is to decrease. And for example, in 91% of the eyes, we have at least the improvement in more than 2 Snellen line. In about 70% of the case, we have the improvement in about more in 3 Snellen line in all the patients. And if you see the results of OCTA, for example, we saw that comparing the OCTA in operated eye with the fellow eye, we didn't see any difference, for example, in deep capillary plexus. And the same thing in the fovea vascular zone. We didn't see any difference comparing the diameter of the fovea vascular zone in the operated eye comparing with the fellow eye. Demonstrating that amniotic membrane do not induce a centripetal movement of a tissue as, for example, the ILM transplant does. And we saw a very interesting phenomenon that, for example, a greater quantity of an amniotic membrane leads to a better supports in the growth of overlying retinal layers with probably better functional results. And we use also the adaptive optics. We focused our exams at the edge of the amniotic membrane plug, where we saw a greater sensitivity at microperimetry. And we saw 2 phenomena. One was the hyperreflective ducts, probably recognized by the software as disrupted but present photoreceptor areas. It was some sliding, was probably secondary to some sliding of photoreceptors on the edge of the amniotic membrane. And we saw also some hyperreflective ducts, probably secondary to macrophage cells or retinal pigment epithelium cells. We didn't see any complication, no inflammatory complication, no IOP complication, no reject of the amniotic by the eyes, and no significant difference between that of patients tamponated with the gas and those of patients tamponated with erythea. This means that we can use a very rapid tamponade, very short tamponade in this eye, also to alleviate the prone position of the patients. In conclusions, we study in 36 recurrent macular holes operate with human amniotic membrane. We have very remarkable results, 100% anatomical success with functional restoration and with some signs of tissue and cellular remodeling. We use air as a tamponade, no need of second surgery, with no adverse event and very easily reproducible. But first of all, a safe and effective procedure. Only to conclude that we have only a few slides about macular retinal detachment, for example, in myopic eye. And you know this, we use in these problems many techniques, but we use, for example, silicone oil, C3F8, evident water endotamponade. We published a new approach to use in this case, also in this case, the amniotic membrane, a very large disc amniotic membrane in this case, at least 5 millimeters of diameters, in order to close completely, to block completely the macular hole in the retinal detachment, in posterior retinal detachment in myopic eye. You see this was one of the cases with large macular hole retinal detachment and the perfect result of the surgery. We operate 19 patients with 100% retinal detachment and about 95% of macular closure with improving in the best corrected visual acuity. In conclusion, amniotic membrane plug is also safe, a simple treatment in myopic macular with detachment. I think we can conclude that amniotic membrane is the most perfect basal membrane and the most precise and safe procedure in the recurrence of macular hole. Thank you very much for your kind invitation.
Thank you very much, Professor Rizzo. This very fascinating technique. I saw first your technique a few years ago, and as you used the amniotic membrane to close peripheral retinal breaks in retinal detachment, and it works as well. Very nice. And I would have one question. I tried this technique, and the first difficulty was the absence of the punch. So I just cut a small piece of amniotic membrane, and the amniotic membrane we have in our clinic, they come from France. These are lyophilized amniotic membranes, and they are dry, and as soon as you make it wet, it rolls in, and it's so difficult to unroll it inside the eye. So what kind of membrane do you use? What kind of amniotic membrane do you use?
I think in Italy we are very lucky because we have a tissue bank, and the amniotic membrane coming fresh for tissue bank. It's very easy to cut. Also, if you don't have a punch, or you can cut with small scissors. And with two forceps, it's very easy to roll the membrane and to use over the macula.
Thank you very much. Susanne, you have to unmute. Press unmute.
One question from the audience to you, Stanislao. It says, good anatomic results correlate with visual gain at what scale? So I think you showed us your data, but perhaps you want to answer this briefly.
The first answer is, of course, we are talking about very, very difficult case. Most of them are extra large myopic eye with more than 1,000 microns, in which we already built the ILM, so we don't have anything to do with to put inside the macula. So for this reason, I think, of course, we have excellent anatomical results, 100% of closure rate, because of the amniotic membrane itself closed the macular hole. But in most of the case, we have at least two lines of improvement in visual acuity. But I have to repeat, I think they are the most difficult case we are dealing of. First one, the most of the eyes are very myopic, more the 29 millimeters of length. With sometimes we have an atrophic area in the posterior pole. You know exactly which kind of eye we are dealing of.
I have another question, Stanislao. You know, you said that the amniotic membrane size is created larger, which makes a lot of sense than the size of the macular hole. But these large holes, they are usually very tightly connected to the underlying retina at the edges. So do you actually use a Meyer's fluid technique to lift the edges, and so that you can place the amniotic membrane under it, or how do you proceed?
Is a very good question, because we start the first case to put the membrane over the macular hole, but in some cases the membrane disappears after the surgery. So of course the last technique is to elevate the edge. This of course is very gentle maneuver, because with some very gentle spatula, because we project this is a bent spatula in order to elevate at least to have some space on the retina. Maybe the technique of carton is excellent to elevate, but at the end, the maneuver is the same. We have to detach the retina, the edge of the retina from alcohol, because the edges are very adherent. We need space to introduce the membrane under the retina.
Thank you. Thank you very much.
There is another question from the audience. Which side do you position the amniotic membrane human, and how? So
we measure, usually we measure of course, with the OCT, the diameter of the hole, and we decide to put for example, in 1 millimeter of the hole, we decide to put 1 millimeter half for amniotic membrane. So these are the simple method to calculate the diameter of the amniotic.
No, I think
does it
meant which side of the amniotic membrane?
Sorry. Yes. We have to put on the retinal peak epithelium the chorion layer, because the chorion layer has some adhesive properties. It remains adherent at soon you touch the retina. So this is the first tip. Of course, you have to put under the retina, in contact with the retina, the epithelium layer, because it is full of growth factors, it's full of stem cells, so of course it has some regenerative properties.
Do you mark the sides? How do you know it, or do you see this on a fresh?
Some surgeons nowadays mark the sides, but if you magnify your microscope, the corneal layer has some soft filaments coming from the cornea. You recognize very, very well there. And the other tip, of course, the corneal layer remains adherent to your forceps. If you open the branch of your forceps, the corneal layer, the membrane remains adherent with the part of it is the cornea.
Thank you very much. This was great. Unfortunately, our time is now close to the end. And I would like to thank again all the speakers, Sophia, Carsten, Lubomir, and Stanislao for this exciting symposium. And I would also tell you that the webinar has been recorded and will be available via the SOE website very shortly. Thank you very much.
Thank you very much, Susanne. And we had over 120 participants during our webinar. This is quite successful. We would like to thank the panelists who presented their presentations and discussion, and we are glad to invite you to the future webinars. Thank you very much.
Thank you very much.
Bye-bye.
Bye-bye.